So thank you very much, Naren, for organizing this fantastic course. And thank you very much to give me the opportunity to talk about these sometimes very challenging tumors. So I will start by dedicating this lecture to my mentor and friend, Professor Michel Zera, who taught me so many things about intramedullary spinal cord surgery. So this talk will be focused upon intramedullary spinal cord tumors with exclusion of coda equina tumors, lipomas, extradural tumors, and tumors of the bulbomedullary junction. All these tumors account nearly 25 to 35% of intraspinal tumors in children. And with an incidence rate of 1 to 2.6 per 1 million children, in a country like France, you have almost nearly 20 new cases a year. Differential diagnoses include myelitis, multiple sclerosis, and syrinx. That's the reason it's very important in front of a syrinx to have contrast enhancement MR, and sometimes can be misdiagnosed by trauma. Symptoms in descending order of frequency. Pain is occurs in 2/3 of cases, back pain. Sensory deficits, then motor deficits, they are present when the tumor is there for some months in 70% of the children. Scoliosis, head tilts, and sometimes 10% of cases, so rare but not so rare, hydrocephalus. So the first message is, with persistent back pain in children, should lead to MR, spinal MR. And the second message is, when you are faced with a painful or left-sided scoliosis, especially if it's a boy, then MR. So in summary, revelation of symptoms are often insidious, and attention must be paid to scoliosis. Pain is the most common symptoms. Motor deficits appear early, but sphincter issues occur late. And as we will see later, pre-op modified McCormick scale is one of the predictors of the functional postoperative stages. Talking about pathology, 85 of these tumors are low-grade tumors, divided into pilocytic astrocytoma and ependymoma. And if you have a child with type 2 neurofibromatosis and a spinal cord tumors, this is an ependymoma. Sometimes high-grade tumors, for example, diffuse midline gliomas, with a median overall survival of less than 1 year, and other tumors, metastasis, mostly from medulloblastoma, anaplastic astrocytoma, and hemangioblastoma in case of von Hippel-Lindau disease, and sometimes ATRT. Most of these tumors are located in the thoracic levels, 5 levels on average. Some of them are thoracolumbar or cervicothoracic, and 19% of them are located in the cervical portion of the spinal cord. Here are some examples. When you see this side, you have an aspect of what radiologists call a big cord, big spinal cord. So that's most of the time, not only, but most of the time, it's an intramedullary spinal cord tumor. And it's like that with solid portions, with cystic portions, and with sometimes edema. Another example of a spinal cord tumor, of a thoracolumbar spinal cord tumor. Here, the post-operative aspects. Another example with contrast enhancement and axial view of this tumor. Another thoracic tumor, thoracolumbar. And sometimes it's very difficult to see the tumor because of the scoliosis. So you can see here the tumor in this aspect of big spinal cord and with a complete removal after surgery. It's not so easy sometimes. But nevertheless, the aim of surgery should be maximization of resection. For example, this cervical spinal cord tumor with brainstem edema and hollow cord cysts was treated with complete removal. It was an ependymoma. It's easier than pilocytic astrocytoma. So I will talk about surgical technique, prone position, sweeping holder, and very important to monitor the child. We sometimes monitor some muscles and anal sphincter, but the most important is motor evoked potential. It must be routinely done when you do such procedures. Here is the intraoperative monitoring. So, as I said before, we monitor some muscles and anal sphincter, but the most important remains motor evoked potentials. Then it is very important to do a laminotomy or laminoplasty, and under operative microscope, dura opening on the midline, and after that, identification of the posterior sulcus, the posterior fissure. You can coagulate sometimes the vessel on the posterior sulcus, and then do very gentle your myelotomy. I will show you a video. And then with bipolar forceps, very gently go deeper to find the tumor. The debulking must be as complete as possible to identify the margins. I personally use ultrasound aspirator with a 1.14 millimeter needle, but other teams advocate en bloc removal of such tumors in the aim to avoid bleeding and avoid tumor spreading. But it's not so easy to do in clinical practice. Intraoperative ultrasound are very useful before opening the dura, and after opening the dura, you can put it very gently directly on the spinal cord, and then the dissection begins to find the margins. If it's easy, that's most of the time an ependymoma. If it's difficult with an incomplete resection, most of the time it will be a pilocytic astrocytoma. And then at the end of the procedures, I advise to close the myelotomy because it's very useful in case of recurrences with, for example, 7-0 stitches. So this is ultrasound guidance. This is done before dura opening. So you are the tumor here, the solid component of the tumor, and a cyst here and another cyst here. So it's very useful. You can see the cyst and the solid parts of the tumor. And this can be repeated after having opened the dura. So just to see you this aspect of big spinal cord. And this is a very recent case because we done it on the 15th of February. Here is the myelotomy after a very careful coagulation of the posterior fissure. And then with bipolar forceps, you will go very gently deeper, and you will see a very strange tumor here, orange in color, and a cyst. It was a pilocytic astrocytoma that could be removed completely. So the procedure with the excision of the cyst wall. And this is the very beginning of the closure. You have just one stitch here. It is very important to close the spinal cord after the procedure, because if you are faced with a recurrence, sometimes the recurrence go on this side, on one side, and on the other side, and it's very difficult to find the midline again. So if you want to see the midline in case of recurrence, then it's very useful to have non-resorbable stitches on the spinal cord itself. So in summary, identify the midline before myelotomy, minimize spinal cord retraction, expose superior and inferior pole before deep resection under ultrasound guidance, avoid unnecessary bipolar coagulation, and remove the tumor. I really think en bloc may be very, very difficult to do, but the anterior part must be removed at the end of the procedures. You have to stop your manipulations if motor evoked potential decrease, and we consider a decrease amplitude of 50% from baseline as significant, or even worse, disappear. Then it is advised to have warm irrigation and induce mild hypertension. And if motor evoked potential are still not present, then to convert surgery to partial or subtotal resection, but not to complete resection, because there is a very high risk of postoperative neurological deficit. It's very rare, but we saw it 3 times. Sometimes you can see a tumor, accidental finding, and in France, we call it, we will follow the evolutionary personal profile. We are all different. Some of this tumor will grow and will require surgery, others not. So we advise a close follow-up, symptoms, and serial MR. The prognosis remains good in case of low-grade glioma, with complete resection around 70%, much better for ependymoma, less better for astrocytoma. And the oncological prognosis depends obviously on pathology, but on extent of resection as well. So this is our first series that was published now a long time ago. At this time we had 21 tumors. We are much more tumors now because we are center of reference in the east of France. And we found an overall survival at 5 years of 81% and a progression-free survival of 67%, again at 5 years. We use pre and post-operatively the modified CORMICK scale. It's very useful. It's from grade 1 intact neurologically, to grade 5, the worst, with a child who is already paraplegic or quadriplegic. And when you study carefully your patients, and when we study the preoperative modified Markovic scale, the postoperative, and the scale at the end of follow-up, so we will see that you can gain one level, or sometimes you have -1 level. So it's not too bad, because you can say to the parents that there will be sometimes a worsening after surgery, but at the end of the day, you can improve and you can be better than before surgery. And sometimes, of course, it's with a neurological deficit. But anyway, we can, I think, minimize it nowadays. I will just point out something that is not so much published, is the postoperative spinal deformities. In our series, sorry, we have an average delay of spinal deformities, post-op spinal deformities of 13 months. And 60% of them required surgical stabilization. Also, we performed an aminoplasty at first surgery. Of course, you can have pre-op deformities, but again, post-op deformities, you must check it for a very, very long time. And if the scoliosis is worse and worse, you can discuss costal distraction system, or posterior, then posterior plus anterior fixations. So we studied one by one all our children. So I will just show two examples. It's the evolution of Cobb angle with time. For example, this child had a scoliosis. Nobody thought that it was an intramedullary spinal cord tumor. So there were no MR, then surgery, then fixation, then premature failure of prosthetic material, and then worsening and worsening aggravation of scoliosis. Another case, surgery very early, 18 months, then aggravation of scoliosis, then multiple tenotomy, costal distraction. So the scoliosis became better and improved, and then extension of costal distraction, radiotherapy, again extension of costal distraction and change of costal distraction, and all these surgical procedures were useful to have a scoliosis that is 50 degrees. So the third message is the follow-up of children on the long term is mandatory, and check for spinal deformity. Very quickly, other treatments, chemotherapy and radiotherapy are both effective, but the gold standard should be maximization of resection. If the resection is only a biopsy, almost all these tumors will grow with time, and the problem will remain the same some months or 1 year after your first surgery. In case of recurrence, we have always to discuss surgery, sometimes chemotherapy, essentially for low-grade gliomas, sometimes radiotherapy, and we have to be very careful with new cysts. if you follow these children with serial MR and you notice that new cysts appear, most of the time is the beginning of a recurrence. In conclusion, there is a frequent diagnosis delay. Surgery is the gold standard and favor maximization of resection whenever possible. Try not to do a simple biopsy, please. Preserve neurological function as much as possible, and additional treatment, chemotherapy or radiotherapy, are mostly for high-grade lesions or tumor progression that is not attainable by a second-look surgery. Spinal deformities remain a frequent complication in the pediatric population, and overall survival and progression-free survival mostly depend on pathology. So thank you very much for your attention.
Thank you very much, Professor Klein. That was a very elegant and very comprehensive lecture on intramedullary tumors. I really enjoyed it. I'll just see whether Dr. Mark Krieger, Dr. Krieger, would you be able to unmute? Do you have any comments, questions for Dr. Professor Klein? While Dr. Krieger tries to unmute, I have got a few questions for you, Professor Klein. First of all, in terms of organization, you mentioned that you are the reference center for east of France. So is,
yes.
Is spinal tumors being centralized in France?
No, it's a very regional agreement. So we cover an area of 6.3 million people in the eastern France, and we are a center of reference for oncology, pediatric oncology, and with time we see much some, for example, craniofacial cases or chiari malformation and other.
Thanks. And in terms of in terms of CSF leaks, and also in terms of what you call, when the cord is rotated so much that you are trying to find the midline, can you your thoughts on the CSF leaks and the rotated cords? Do you have any comments on that? Thanks.
Well, the CSF leaks still remains a problem, but I think that the closure of the dura must be really obsessive in such situations. So really obsessive, and of course these tumors are challenging, and if you have a rotated spinal cord, it's more and more difficult. So in this case, it's sometimes very difficult to have a complete resection, but here again, ultrasound guidance can be very useful and can show you solid tumor remnants, at least at the beginning of the procedure. Later on, it's much difficult, but obviously it remains a very challenging situation.
Thanks. And one more question. In UK, sometimes we have different perspectives between the surgeon and the anesthetist. If the neurophysiology signals fall down, do you increase the blood pressure and try to see whether the signals come back?
Yes. That's the first thing. Yes.
And do you have any protocol by how much you increase or anything?
No. There is no written protocol with that. I'm confident with my anesthetist. No, it's not an important variation of pressure, but so I'm not sure it needs a real written proper protocol.
Brilliant. Thank you very much again.
Thank you very much,
Professor
Naren.
That's fantastic. Thank you. So now it brings us to the